Hello, I'm Nadia Moore, and I will be presenting our scope of work for quality improvement. We worked with the ANPHA Midwifery Association to help try to enhance the accreditation process for midwifery schools. I'll begin by talking about some background. So from 1996 to 2002, there weren't really any new midwives that were educated in that period due to conflict. And then in 2002, there was a drastic increase in the number of midwifery schools. So an accreditation process was necessary in order to ensure the quality of maternal and child health services. So the Ministry of Health created the Midwifery Education Accreditation Board and National Standards for Accreditation. This board is a semi-governmental body, and its members comprise of Ministry of Health members, members from the AMA, which is the Afghan Midwifery Association, and NGOs. However, the problem with this board is that it is advisory and it's entirely dependent on donor funding, and it currently only has the capacity to accredit hospital and community-based midwifery programs. So there needs to be their capacity needs to increase so that they can also accredit the private sector midwifery schools to increase quality. Therefore, at AMA, the Afghan Midwifery Association, asked us to institutionalize the accreditation process. So we created for them a literature review of some of the accreditation process in 2 different countries that are comparable, a process map, which Maura will be presenting so we can find some bottlenecks in the process, and ultimately a roadmap for quality management process of accreditation to increase their capacity to accredit all schools. So the 2 case studies that we looked at were Malawi and Australia. Malawi, the reason why we looked at Malawi is because they also have an equally high maternal mortality rate of 460 deaths per 100,000 live births. They also follow the same international Confederation of Midwives guidelines for accreditation. And ultimately, Malawi looks at Afghanistan as a model. We also then looked at Australia as a model for Afghanistan to look to, and the reason we chose them was because they also face similar challenges. Australia was a very fragmented system initially, and now it's streamlined across all regions under one Australian Nursing and Midwifery Council, which did not start out as an autonomous body and now is.
This is the process map for accreditation of both midwife education programs and individual midwives. They're kind of all streamlined into one. It's clearly a very long and complex process, and this was recently overhauled in 2002 when the board was established. So it is based on a SBMR model, which is standards-based management and recognition. It's broken down into 4 phases. Phase 1, establish standards. That's the first portion of this map where the board was forming, and they established the standards that would be applied to the schools. Phase 2 is implement standards. That is mostly done through a series of self-assessment exercises that the school's administrators actually do in order to determine whether or not midwives and their programs are meeting the core competencies that are established by the board. 3, measure progress. That's a combination of self-assessment and then a binding outside assessment that is administered by the accreditation board. And 4, reward achievement, which is with accreditation of the program or licensure of the individual midwife. So we did establish a few bottlenecks here. I I want to emphasize the fact that because this process was recently overhauled, this is actually working very well on the ground in the country. They've made a lot of progress with this. However, due to resource constraints on the accreditation board, there is some time lag that happens in here. They, first of all, have a donor funding resource constraint on unaccredited programs. So basically, programs that do not achieve competency cannot receive donor funding, which kind of strands them at their most vulnerable period in this entire process. So we see a lot of programs that are looping in this portion right here, which is the self-assessment portion. So you don't achieve this standard, and then you just kind of keep going back. You don't have any injection of new resources in order to improve. Additionally, there's a backlog of tests on the board's end. They cannot administer tests immediately once programs have internally reached their competency, and they request a binding assessment. There is a time lag there. Obviously, the board gets a lot of requests, particularly when you have programs who achieve competency and then a couple of years later they need to be reevaluated and be reaccredited, so it's just kind of like an endless cycle there. Additionally, the board lacks the resources in order to oversee reaccreditation of midwives and programs, so that standard is not as strictly enforced as they would like. Many midwives achieve licensure and then are supposed to, every 2 years, get recertified, and no one's really checking up on them, so they found that midwives are not, in fact, getting recertified. So once the level of competency is achieved, it's quite likely that the skills are degrading over time.
Now I'm going to be talking about the roadmap to quality management of the accreditation process for midwifery schools. So the AMA asked us to create them this roadmap. So we created 3 phases that we recommend that the AMA go through along with the current accreditation board. So we begin at phase 1, which is planning. Basically, we want them to plan for the establishment of an independent accreditation council. So first of all, they need to establish an evidence-based proposal because the Ministry of Health currently has a lot of resistance to giving this accreditation board autonomy because they feel they're going to lose their power over the board, which is essentially true, but the AMA needs to prepare a proposal that shows the benefits of this transition, and also maybe present some similar councils that have benefited from a similar transition. Also, a preliminary organizational chart and budget needs to be created that outlines leadership and responsibility in this new council, but it needs to be flexible for feedback later from stakeholders. Also, they need to meet with these stakeholders, the members of the Ministry of Health, NGOs, and the private sector, in order to discuss this proposal. Then they need to create a task force, for the transition phase to help with the process of transitioning of the authority from the current board to the new autonomous council. Phase 2 is the establishment of an autonomous council. So first they need to create a constitution, and this needs to happen early on because all stakeholders need to be on board, and they need to agree early on goals, activities, and authority. They need to finalize the organizational chart and budget with stakeholders, and they need to create a strategic plan that outlines...
30 seconds left.
Okay, they need to create a strategic plan. Then the last phase is just establishment of the independent, sustaining the independent council's autonomy through policy development, reaching out to the private sector, increasing private sector accreditation fees for possible increase in funding, and then also establishing external assessment teams that are voluntary, which will enable the board to function.
Any questions?
Everything's crystal clear. Could you go back to the process map? I was the white, the yellow. Are they squares? Are they called? I can't.
They're
quite-
call-outs.
They're call-outs. Okay. Just trying to work out what they were. So on this, you haven't actually identified. You talked us through where the bottlenecks were and the problems, but you haven't identified on this the specific.
They're identified within the analysis section.
Okay.
Yes, so we have in the report we'll have the map, and then following that will be the analysis of it.
Okay.
So, pardon me if I just misunderstood. So this is really for programs trying to become accredited, but you haven't really looked, I'm asking, but you haven't looked at, confirming that existing programs are meeting accreditation, or like, what happens if they aren't meeting standards?
Programs were closed at the beginning of the initiation of this standard. So basically, this was kind of applied in two phases. There was a pilot group of programs and then a group that felt that they weren't ready, and so they waited a couple of years and then they administered the test to those schools. Basically, nobody was allowed to graduate any students until they had achieved competency here. So the programs did, in a sense, shut down until they were assessed.
Can you clarify a little bit on those examinations that are going to provide to midwives? That final step exam about the examination? Yeah.
Oh, okay. So they have like a board exam that any medical professional would take, but there's a backlog of them, and taking them, and even being able to access them. So they go ahead and give the midwives their license, and they can go ahead and practice, and then at some point, hopefully take the exam.
They're supposed to.
They're
take
supposed
the
to.
exam, but it doesn't usually happen.
And I believe that Maura identified that as one of the bottlenecks and gaps as well.
So is it the board that's doing the hiring of the midwives, or because so is the endpoint that you have hired midwives, or is
The board doesn't hire the midwives. It's any institution or any facility that wants to hire the midwives that does the hiring, but they're not allowed to be hired unless they have their license from the accredited institution, which the board has established the standards for.
What prevents, like if you've given them their license and they haven't taken the board, what prevents them from